All right, so this is going to be the last of chapter 16. The last couple sections, we'll talk about the cranial nerves um, and then move on to the last exams with this. So let's get started on cranial nerves. We know these guys, we've already had to memorize them, so this should be repeat information. But now we're going to talk about the different tests that are associated and testing those specific cranial nerves. So we've already talked about cranial nerve number one, and that's olfaction. That's going to be your sense of smell. Is it working properly? Can you smell what's around you accurately? My dad had um, played softball one time, and he went up for a pitch, and he'd gotten in a few scraps as he was younger too. So he had broken his nose a few times in fights when he was younger, and then in my lifetime, he went to get a pop-up fly, and he missed it, and the ball came right back in his face and broke his nose. And so he had trouble smelling because, again, those nerves are coming through the cribriform plate up there in your nasal cavity, and that all got damaged. So some people can't smell properly. They're losing that sense of smell. And if they are, that is anosmia. Anosmia is losing your sense of smell. And that, again, is cranial nerve number one. What if you cannot see correctly? Most of us do not have proper 20/20 vision without some help, without contacts, without glasses, without some kind of help. So let's test that optic nerve. Make sure that what we are seeing is correct and as clear as possible. If we are losing vision and osseous loss of vision, and that could be determined using the Snellen chart, which I think all of us have probably seen at some point in our lifetimes, detecting this and then having the ophthalmologist ask you one or two, where is it clear? So you will go through this and shout out, the letters that you believe they are, even if they're not correct. You're hoping they're correct, and you can determine, here what the vision level is. What can you see? This is the Snellen chart. It assesses cranial nerve number 2, vision, your optic nerve. Something that could impact your optic nerve is pituitary tumor. I actually have a friend in tennis whose daughter had pituitary tumor. She still has it, by the way, because it's in a really important part of your brain. And so that same important part of your brain is where the optic nerve goes back. And so if you have a tumor on your pituitary gland and it grows, it compresses and puts pressure on the optic nerve. And so when my friend's daughter went into St. Jude's to have that tumor looked at and possibly removed, they weren't able to get it all. And she undergoes radiation to try and keep it under control. But when they did remove part of that tumor, she suffered with some of the, when we go into motor control of the eye, she suffered with strabismus. She suffered with diplopia, where you're seeing double vision. She had headaches because of the double vision, because her eye moved, it shifted. She had strabismus. She was seeing two of everything, all because the optic nerves were going through there, and her other cranial nerves were going through that area, and that pituitary tumor pushed on those things, and so she was having trouble. Hearing and balance. So which cranial nerve is that? Remember, this one is going to be number 8, where vestibulo was balance. Cochlear is hearing. Vestibular cochlear nerve. Cranial nerve number 8. And so if we were having trouble with hearing, that could be deafness. And we're going to talk about the different types of tests to determine exactly what's going on. And then equilibrium was your vestibular with your semicircular canals going down into those utricles and saccules down there. So you can conduct a hearing test. Again, I'm going to tell you to watch the videos because it's just better to watch the videos and see somebody actually perform the test than me tell you about it. But I'm going to tell you about it anyway. So with hearing, you're going to need to know, are they being able to hear due to the sound waves traveling through and hitting the ossicles? Like talk about hits the tympanic membrane, then it's malleus incus stapes, and that's going to push on the cochlea, and then we can hopefully hear that way. If something's going on with that, you might have conductive hearing loss. What if that all works fine? Your ossicles are working fine, but the nerve is damaged. So that would be sensorineural hearing loss, where the nerve itself, your vestibulocochlear nerve, maybe that's something's going wrong with that cranial nerve. So how can we try and figure out what it is? We can use the Reen's test and the Weber test. And so you can put the tuning fork on your mastoid and see if it's conducting the sound that way. And then you can lift it up and see if the sound waves travel through the ear, through the ossicles. And that can see possibly, is it the ossicles that are the problem, or is it the nerve itself? Are we hearing it when it's on the mastoid and not hearing it when it's out in the air? So our ossicles are not transmitting the sound waves through like they're supposed to, but we can still hear it if it's conducting through. So Reen's test is going to help us do that. And then Weber's test is kind of cool. It's going to take that tuning fork and it's going to put it on top of the head. And you will be able to ask the patient, can they hear the sound in both ears? Do they hear it? Because they might hear it from one ear different than the other ear. And so it may be louder in one ear than the other ear. That's going to be Weber test. It's kind of cool. Our ears, again, are located right here, the same level on our head. So our sound waves are hitting us at the same time. And if we hear one coming in from one side versus the other, we know that the object is over here. Owls are kind of neat. I know we're not talking about animals, but owls are kind of cool because their ear canals, one of them is higher than the other. So not only can they determine if the object is in front, left, or right, but they can also determine hearing height level, because if it's lower to the ground, then we're going to hear in the ear canal that's lower down versus the ear canal that's up here. And we can determine about where that mouse is, even if we can't see him. Maybe that mouse is hiding under the snow. And owls are kind of cool because their ears are different locations, and that allows them to not only hear left and right, but up and down, and to test dimensions. So they can really hear in 3D, which is pretty cool. We don't do that, but they can. So the Reen's and the Weber's tests are different tests that can assess, are you hearing through the same in both ears? Are you having hearing loss because it's conductive, or are you having hearing loss because it's sensorineural? Can you taste correctly? So those are going to be a few cranial nerves. Remember, we talked about different parts of the tongue and which part was innervated by what. So gustation could be facial nerve, and that's going to be the anterior 2/3 of the tongue. And we could also talk about the posterior 1/3 of the tongue with the glossopharyngeal nerve, and then there is the vagus nerve that's going to also help out with these guys. Trigeminal is going to help with sensation. So trigeminal is going to be sensations of the face. It's also going to help with chewing and mastication. So this was one that was a mixed or both. You will have to know this on the upcoming exam, by the way. Remember, is it sensory? Is it motor? Is it both? We need to know these things. For the trigeminal nerve, that's going to help us with sensing. So one of the tests that they perform in that video that I told everybody to watch, I want to say she's doing it, and you take a Q-tip, and I'm going to pretend this Q-tip, and you got your soft, fuzzy Q-tip end, and then some Q-tips have that wooden, it's just a wooden dowel, kind of tiny twig piece, or you could just use a Q-tip at home and maybe snip off the end of the Q-tip, so that what you get is something pointy, just like my Apple Pencil. And so what you do is when you're assessing sensation, you don't let the patient see, but you'll go from soft end to pointy end, and they will tell you, is it dull or is it sharp? Dull or sharp, without looking at what you're doing. And so you can do this on the face, and you can do this in other parts of the body to determine how their level of sensation is operating. Gaze control, those are going to be all the other cranial nerves that we talked about, innervating all of the muscles on the eye. So we have oculomotor, that was 3, trochlear 4, it's going to be superior oblique. Our abducens is going to be the lateral rectus. Oculomotor moves most of the other guys. So how is the eye moving? Do you have strabismus like this person does, where you've got internal strabismus? Do you have external strabismus where it's going towards the opposite? That was what was happening with my friend's daughter with the pituitary tumor. So her nerves, her cranial nerves were impacted, and she suffered with strabismus. Maybe you've got saccades movement where you have rapid eye movement. It's hard to, like, the examiner is going to ask you to look at the pen, it's going to go closer and further, and your eyes need to adjust to that. And then, follow it with your eyes only, not your head, and move this way and this way. And they are assessing your eye movement. Is it smooth, or are you getting rapid eye movement going back and forth? Are your eyes adjusting as it moves closer to you or further away? Do you have convergence? Will they need to accommodate? Do you need to have accommodation? As we all age, usually our vision gets a little, poorer, and so you may have to have it assessed and get accommodation. You may need corrective lenses. Vestibulocochlear reflex, making sure all of this is working properly. Nerves of the face. Those would be ones that we've already mentioned: facial, glossopharyngeal. If you cannot taste, we talk about the first 2/3 facial, and then glossopharyngeal is the last ones. If you couldn't taste anything, your loss of taste was aglesia. And then we had a picture of this, picture of the Bell's palsy. No, it's in here somewhere. There it is. So muscle weakness on one side of the face is Bell's palsy. It could also be a sign of a stroke, like we mentioned, a ischemic stroke. Could be where you lose function on one side. But if it's temporary and it will go away in a little while, in a couple days, then it's Bell's palsy. And so this is kind of a picture of that loss of sensation. And the muscles that are going to help move the neck, again, are accessories. That's going to help us move and shrug our shoulders, move our head. Sensory and motor exams. This is going to test our sensory stuff. So I was telling you about the cotton ball. We're going to do, is it rough? Is it sharp? Is it dull? Is it sharp? Is it dull? And just do that in different places around the body. Other tests that you can do to measure sensory information is the Romberg test, where you stand straight, you put your feet together, and close your eyes. Can the person maintain their balance without their eyes being open? That's Romberg test. We are assessing, again, sensory and motor. Another thing that you can assess, that you may put your arms out, and the examiner can assess muscle tone. So if you were asked to put your hands out like this, I'm trying to demonstrate it here, not look like a weirdo in the parking lot on the side of the highway. So you're putting your hands out like this, and you're not thinking about it. And then unconsciously, one of your hands might start to pronate down like this. And so you may have pronator drift, and that may be a sign of your upper motor neurons may have a lesion, they may be damaged. If you are seeing pronator drift, you may also have just lack of muscle tone. The muscles may be flaccid. That could be a lower motor neuron damage. We discussed reflexes. Of course, this happens almost every physical exam, where you take the little hammer, and we already talked about the stretch reflex on your knee. You can do one on your ankle and see how your foot reacts. Another test that you can do is Babinski. And so we've got a video demonstrating that. But somebody's going to take something sharp. It could just be a pen, or I don't know, it could just be a fingernail. And the patient will have their foot exposed, and you will run it under their foot. And so normally on a good Babinski reaction, well, let me explain. When you're first born and you touch baby's foot, baby's toes are going to go, "Wah," and they're going to spread out like that under Babinski. You touch their foot and their toes spread out. As we learn to walk, those toes start to learn to curl. So a normal reaction with Babinski's, if you do this on the sole of the foot, toes should curl down like this. If you do a Babinski and you are marking the underside of somebody's foot and their toes splay out, then that is a sign that something's going on. So there may be possible damage that is giving you that sign, that Babinski sign. So are the toes curling, normal, or are they splaying out? That's not normal. That should not be happening. So watch the video. You can see it in action. It's kind of cool. Another thing that we can do is measure dermatome. Again, the nerves are going to be associated with the parts of the body around there coming off of that. Did we talk about everything? We talked about Babinski's. Let me check my notes. Yeah, there may be paralysis, of course, where things are flaccid and they're not working. You may have somebody that is hyperflexing. They've got spasticity. My half brother was 16 and he was driving a four-wheeler at Dolphin Island off the Mobile coast, and he was doing it at night on the beach, and he didn't see where he was going, and he flipped the four-wheeler and it landed on his head, and so he suffered major brain trauma. We thought we were going to lose him, and he's alive, but his quality of life is not the same. He was very underwent severe trauma, and so some of his muscle movements are like this. He's got spasticity where it's hard to stretch out. He's hyperflexing where things are really tight, really tight. So that is another assessment of motor. Can you move your arms and your legs like you're supposed to? All right, so number 5, coordination. Coordination is your cerebellum. That's going to help us coordinate large amounts of muscle movement in the body. And so you may have the gait test where I told y'all that the person may walk toe heel, and see how they're walking that way. Have the patients hold their arms out and see how are their hands. Are they shaking? Are they still? I'm a little hungry, so I may have shaky hands. I haven't had breakfast today. But are there tremors going on? When they hold their hands out, are they resistant to pushing against it? Push against my elbow and make sure that you don't let me move your way. And then, try and keep your hands together as I push them apart. That's all determining motor response to things. How is your posture? How is your gait? I mentioned that my dad had Parkinson's, so he had a stooped posture, and his gait was not good. He could barely pick up his feet, so he had shuffling feet when he was trying to walk from place to place. If you are missing these coordinated movements, it could be, you can't put your finger to your nose. That would be, if you've lost those voluntary coordinated movements, that's ataxia. And so again, here's the cerebellum that coordinates all these things. Assessing posture, gait, ataxia, you've lost those movements. There is a video here that shows you somebody who's having trouble with those movements. I was telling you about my half brother. He has ataxia. It's very hard for him to do things. He couldn't walk for the longest, and he can walk with a cane now, but those movements are tough. He looks a lot like the person in this video. It makes me kind of sad just to watch it. Other things can affect this, though. It doesn't have to be trauma. It could be stroke. It could be somebody who's just intoxicated. If you've ever watched, police dash cam videos of people that are intoxicated and having the roadside test, they may have ataxia because they can't do what it is that the officer is telling them to do. Okay, so that is the last of the content. You're all done. Yay! Celebrate. And then after you celebrate, then it's time to study and get back with it. So we have the test coming up. The test for exam 4 is going to be on Wednesday. Lecture exam 4 is Wednesday, the last official day of class. And then I pushed the final to Friday. So exam 4 is Wednesday. The comprehensive final is Friday. And so that comprehensive final is going to be all of the exam questions that we've had before, randomly selected. So instead of exam 4 being 100 questions, your comprehensive final is going to be 150 questions. And they will be, again, randomly pulled from all 16 chapters. But I won't do an exam review for the comprehensive final because everyone's test will be different. Everyone will have different tests. So the studying that you have done for exam 1, for exam 2, exam 3, and exam 4, that same studying, those same questions will be on the comprehensive final. So go back through and whatever materials you use, whether you made the study guide, which I hope all of you did, however you chose to study for those exams, go back through those materials because those same questions are going to be on the upcoming final. So if you have questions, shoot me emails, and I hope to hear from you. Hopefully I can hear from you at the upcoming